our President, Dr. Khincha, Secretary, Dr. Leo Joseph, Secretary General, Dr. Pachore, myself, Dr. Dipak Dave, along with my colleague, Dr. Krishna Kiran, the Education Committee members. We all welcome you for this first academic program of this year. As you know, that we have been doing these programs for last many years. And before we start this first lecture of this year, I request our President, Dr. Khincha, to say a couple of few words.
And thank you, Dipak Bhai. Thank you, everybody. And welcome to all participants. And I hope that all the participants will spread by the word of mouth about these particular online teaching programs, which have become more and more receptive and more in the space of all this learning and teaching programs. And I must thank Dipak and Dhanasekara Raja and now Krishna for all their hard work in piling up this particular program so that you, the participants, get the best out of it. And, you know, this is a good platform because many people have to travel to hear these experts, but here we have it online. So I hope that you participate, interact, and spread the word about this program. So Dipak, thank you very much for all your efforts, along with Krishnakant and with the old team Dhanasekara Raja. And I welcome all the speakers, for both the speakers of today. And I hope that we have a good interactive session.
Yeah, thank you, Dr. Yeah, thank you, Dr. Khincha. So we have, as routine, we have two sessions, the one hip topic and one knee topic. For the hip topic, we have a very well-known surgeon from Pune, Dr. Rohit Luthra, who is going to talk on the direct anterior approach. Is this a perfect approach to the hip? So he's going to speak on to that. And subsequently, the next speaker is going to be Dr. Dhanasekara Raja from Coimbatore, Ganga Hospital. He was my colleague, as Dr. Prem said, for the last 2 years. Now I've been joined by Dr. Krishna Kiran. And Dr. Dhanasekara will be speaking on the use and role of augments, sleeves, stems, cones, when we use, why we use, how we use. So for that, the first talk, I thank Dr. Rohit Luthra for accepting our invitation and request you to share your screen and give your thoughts on the direct anterior approach. He is a very eminent surgeon, very well known for DA, and many people have been doing visiting him, doing the fellowships for this particular subject under him in Pune. Over to you, Rohit.
Yes, sir. Thank you. Thank you so much for the honor. I'm obliged to be a part of this meeting, and I would definitely hope that this thing will benefit. So I'll divide my talk into two parts. First, I'll give you a small introduction about what DA is with the help of PowerPoint, and then I'll show you a small video, a 7-minute video, in which I'll show you the whole surgery. I'll take you across how the surgery goes about. So I think we'll start. Just going to share my screen. Yeah. Is it visible?
Yes.
Yeah. So coming to the direct anterior approach, this is an approach which I started doing since 2019. It's been 6 years I've been doing this approach. I took up this at 2017. I did a couple of surgeries and I thought it's too difficult and caused some early hiccups. And then I had given up this approach. I said my posterior approach is better because not causing any problem. But eventually I then again had this itch of doing it again. So I again started doing it in 2019. And since then, I think we've performed more than 1,300 hip replacements with this approach. And all the patients are doing pretty well. So I'll tell you how exactly this approach is making a difference. So what is an ideal approach for hip? An ideal approach is an approach which should have minimal soft tissue release, minimum soft tissue dissection. It should not go through or cut any muscle. It should give adequate exposure to the femoral head and the acetabulum so that the implant placement and the alignment is perfect. It should cause minimal damage to the neurovascular bundle and should not cause any risk to any nerve. Like, if you go to a posterior, sometimes there's a risk of injuring the sciatic if you're in your early days. And it should also have minimal operative time and blood loss. It should provide less post-operative pain, provide early mobilization, and restore the offsets. This is the most important part, because for our patients who are coming for hip replacement surgery, and if I do a hip replacement, if I lengthen or shorten his leg, he'll be very unhappy. So this is a very big factor which comes, and an approach should be suitable so that the surgeon is confident post-surgery that he's sure that the the limb lengths are same. It's a very stable and full range of movement is there with the hip, and he can, so that if the surgeon is very confident on table, so the patient can do all his movements without any restriction. So this is an ideal approach. And we all know that hip can be approached at so many, there's a 360-degree, the hip can be approached. We have posterior, the southern approach, we have posterior lateral, then direct lateral is the hard hinge approach, anterolateral, Watson Jones, and then comes the direct anterior. So there are so many ways we can approach the hip. But why DA? Why DA is because it's not only the patient who's lying supine. So patient is very comfortable during the surgery. He's lying supine. He has no shoulder pain. He's not moving around all the time. So when we're doing a hip replacement surgery, and if the patient is, if you're doing a lateral or a posterior approach, most of the times the patient starts complaining, my left shoulder or the right shoulder is paining because the dependent shoulder is getting pressure, and he tries to move. So what happens is that at that time, even if pelvis is moving, so to avoid that, the patient is in supine, he's very comfortable lying down flat on his back, which is used to, and there's no problem. And also the anesthesia is very, very comfortable. So in case if your surgery is getting prolonged or there's some due to some reason the patient's anesthesia is not effective, so the anesthetic is very easily able to convert into a general anesthesia because the patient is supine. He can put in a tube and things can be sorted. So why DA? Because DA, coming to the second point, this approach is a true internervous and true intermuscular approach. So we are not cutting any muscle. We are not going in between any plane. So we are going in between two muscles, which is the sartorius and the tensor fasciae lata. So these two muscles are going through. So and in the other approach with the posterior is a intramuscular approach. So we're going through the muscle. So this is the true internervous intermuscular muscle plane. So this is the approach exactly when we draw it. So the sartorius and the TFL, this is called as a uterus interval, and this is where we go through, and directly then deep to sartorius is rectus femoris, and directly we are on the capsule of the femoral head. So we are not cutting any muscle, and the dissection is very simple. The patient has minimal postoperative pain, and since there's no muscle cut, not much of soft tissue release, the hip is very stable post-op. So you can guarantee the patient that he can do all his movements, and you don't have to give him any restriction like don't sit down, don't bend forwards, don't sleep on his sides, don't erect the leg. So here you have no restrictions. The patient can lie on the opposite side, same side. He can do adduction. He can sit on the chair on the same day. So this is a game-changing approach. So direct anterior approach basically is also called a Smith-Peterson approach. And the indications for this approach are open reduction for a congenital dislocation of hip. You can perform a total hip replacement. You can do synovial biopsies. You can excise pelvic tumors or drain septic arthritis also through this approach. So the position of patient lying supine, flat, we do drape both the legs together so that the surgeon can go at the foot end and check the limb length. And this can be performed on any normal table. Initially, this approach needed a special table called as HANA table, which was a special kind of table which had a fracture sort of attachment. You can give traction, the table can extend, you can do adduction, internal rotation, external rotation. So that is a special table which is worth more than 1 crore, but we have modified the technique and we're doing it on a routine normal table with normal instruments. So when I started this, we were using all normal instruments, and we have mastered the art of releasing. And once we get a good release of the superior capsule, it's very easy to perform this approach. So the incision is approximately 3 cm distal and 3 cm lateral to the ASIS, and it extends distally roughly 8 to 12 centimeters. And so this is where the incident would be. And it's very straightforward. So this is the ASIS. And now I'm doing most of the approach with the robotics. So you can see the pin sites. And we're doing a lot of robotic diet anterior approach hips. So as we go down, once we dissect the superficial fat pad from the tendinous fasciolata, so you see there's a zone which is called as a transition zone. So this muscle is a white muscle, this is sartorius, and the dark or blue colored muscle is the tensor fasciolata. And this interval is called as uterus interval. So this is where your LCF and the lateral cutaneous femoral nerve is there. And so to avoid injury to this nerve, we go 1 centimeter posterior to it, and we take an incision on the TFL fascia on the top of the TFL muscle. And then we use this flap as a protection for the nerve, and we can retract the nerve medially, and we can go between these two muscles. So you have to identify this muscle. This is the most important part. So a few tips for identification are the TFL muscle has perforators attached. It looks blue and has multiple perforators, while the sartorius muscle is more whitish in color and has no perforator vessels going through it. So this is very important. Once you release this, you elevate this with a hemostat. You can then put a dissecting scissor and underneath, and then you dissect the TFL muscle away from the fascia, and this fascia will act like a sleeve to protect the nerve. And then you incise the fascia. Then what you do is you to retract the muscles. So you retract the sartorius to supply the femoral nerve, TFL is by the superior gluteal nerve. So it's a true superficial internervous plane, and that's how we go deep. And once you're on the deep part of it, you are going exactly on the capsule of the femur. So there's no other structure. You can see a rectus femoris muscle on the top of the femoral head. You retract this medially. Then there are three circumflex vessels which come in the way. Roughly, we call them as three sisters, which we have to cauterize or ligate, because this is the only bleeders which you can find in the whole approach. There's nothing else. No other neurovascular structure comes in between. And once you do this, you go deeper. This is a capsule which you can see, and then you have the rectus femoris and the gluteus medius. So in between them, there's a deeper internervous plane, and this is the anterior part of the capsule. Then you put a few retractors. You cauterize these vessels nicely so that they don't bleed. And then we put one of the retractors superiorly at the saddle of the femur, one at the inferior capsule, inferior part of the neck. One we put medially across the anterior column, and one we have, this is optional. You can avoid this. If you can offer good exposure, you can keep this just medial to the TFL and lateral to the vastus latalis muscle. So this is how you expose the femur, the hip, and then you incise the capsule. Then you can perform your neck cut. And once you expose the neck cut, and you can remove the head with the help of the corkscrew. So the advantage is it's a muscle sparing approach that gives you better stability than any other approach. The recovery is faster. It has better pain scores. The length of stay in the hospital is very, very less. So I was a posterior surgeon. I was keeping my patients for 3 to 4 days post surgery. And now since I've become an anterior, my patients who undergo a single hip, we are discharging them on the same day or the next day. Within 24 hours, they are going back home with minimal pain. They're able to sit on the commode. They're able to sit on the chair. The implant placement is perfect. The biggest advantage is you can use tools to make sure your implant placement is perfect. You're restoring your offset correctly. So you can use either fluoroscopy. You can take live X-rays because the patient's supine. You can easily take X-rays on table and see how your implants are going. Or you can also use robotics. You can use robotics while doing a DA easily, and you can get perfect placement of implant, recreate the offset, recreate the limb length. And once you put in trial, you can go at the foot of the patient, you can palpate both the medial malleus, and you can see whether your limb length is equal or not. So there are some downsides initially. So it has a high learning curve to make sure you're going the right way. So it's like if you go in the correct alphabetical order, you will not have any problem. So you have to follow the certain steps. You have to have a very good team while doing the surgery. You have to have good assistance. You have to have, it's like a pit stop when you see a Formula One race. Everybody has their own role. So this surgery also has a pit stop. It's like a pit stop in Formula One. So you have to have good team. So there are dangers which can happen during surgery. You have to make sure that you are away from the lateral vitreous nerve of thigh. The femoral artery is very, very medial, so it doesn't come. You cannot see it through the approach because we are going more lateral. And there's a artery which runs between the sartorius and TFL is ascending lateral circumflex, which you have to cauterize so that there's minimal bleeding which is happening during it. So the limitation of this approach, it's a limited femoral exposure. But as you go down your learning curve, if you once you cross maybe 100, 200 cases, then you can start taking more and more difficult cases. We are doing a DA for dysplastic hips. We're doing revisions with this. We're doing stem revisions. We're doing total hip replacement revisions with this. And we can even do certain dysplastics, like you can do type 1, type 2, maybe some type 3 also, but type 4, you cannot do it. The other answer is you cannot access the posterior column of acetabulum through this. However, you can remove all the osteophytes, even big osteophytes posterior are easily removed. And you can do it in DDH and short neck patients also. So I would advise for beginners who are learning this approach, do not start with a difficult case. Take a very simple case. Take a patient who has a valgus neck, who does not have a short neck. Take a patient who in which you can get a good area about trochanters, called as AAT. There's a distance between the gritted trochanter and the ilium. So this distance should be more. If this distance is small, then you will struggle in getting the femoral exposure. And so DA is also possible in various, once you cross that learning curve, you can do in various cases like revisions, dysplastics, you can do in protrusio, varus necks, and everything. So this is these are a few slides of how it looks like. And there's a pre-op X-ray, there's a post-op X-ray, which we've done, and it looks perfect. And the biggest advantage is, we are doing a lot of bilateral simultaneous hips on the same day, under same anesthesia. Under spinal, we are doing both the hips, and patients are walking easily. This is before surgery, and this is second day after surgery. He's walking without walker, without stick, with minimal pain. So this was my talk about the introduction of the approach. And then I think I will just move to a small video in case if everybody wants to see. I will this is a live surgery we had recorded pre-live. So this is a patient in which we had a bilateral hip, and we were Dr. Dave. I'm good to go, or should I?
Yeah, definitely. How many minutes?
This is a small video. Maybe I'll run it fast, around 7 minutes. Is it okay?
Yeah, fine. Go ahead, please.
Yeah. So these are the AP and lateral X-rays of this patient. And so while preparing, we do give a spinal anesthesia. We mark the site. We are using a bilateral totally replacement drape for a total hip replacement. So it's a TKR drape which we're using. And we mark the site. So we mark the ASIs. Then we mark 3 fingers below and behind the ASIs. There's the incision mark. And this is where I will take the incision. This is the draping of the patient. We prepare both the legs. And this is where we will start. So its incision is around 8 to 10 centimeters. You incise the skin, then you go to the subcutaneous fat pad. Then you make sure that you're not going too deep because there is a TFL fascia. You have to go a little slow here so that you don't cut through the fascia directly, because you might then go at a wrong interval. So you have to get a good exposure. Once you get a good exposure, then you identify the plane, which I was telling you. And so this is called as gluteus interval. Then we will separate this, and we will identify so these are the subcutaneous perforators. You can see these are perforators going into the TFL. And this is the uterus interval I was talking about. And then you go 1 centimeter posterior to uterus interval, you incise this fascia. You can use a scissor, or you can use a knife. And this I was talking about, this is very important because I'm going more lateral. I can use the sleeve to protect my LCF and nerve. And then the sleeve is very good, it can elevate. And this is a TFL muscle. Once you are deep, then you retract, you go deeper. You will find a few vessels, which you can see here. And I'm working on the anterior capsule of the femoral head. And I'm using a Cobb's elevator to elevate the rectus femoris now. So the rectus femoris muscle. And this is how we place our retractor. So there's one which goes at the saddle, one at the anterior part of the column, and at the inferior part of the neck, and this is the vastus latalis muscle. So we need 3 retractors, and you can see the whole hip very nicely. And so reaching the hip from the skin is less than 2 to 3 minutes. Then we incise the capsule in inverted T form. And I usually prefer doing a capsule repair post-op. So I will tag the capsule and keep it, and I will repair it later on once the implant is in. So there are various studies that say that even if you don't repair the capsule, the dislocation rate does not change. But I prefer repairing it because it gives me a better idea and much better sleep at night. So then we mark the neck cut. There are various neck cutting guides. We mark the neck cut. And then we cut with a saw and then complete with the osteotome. And then you can use a corkscrew on power or on hand, and you can just rotate so that you release the soft tissue attachment and you slowly excise it. So once the head is out, we will start preparing the acetabulum. So for the acetabulum, there are 3 retractors which are very important. One is so before we go into the acetabulum, we are going to do a pubofemoral release. So what I'm doing is I'm putting a bone hook deep, and I'm doing a superior capsule release. Then I also perform the pubofemoral release. Once the pubofemoral release is done, we can put retractors across the acetabulum to get a good exposure. So this is at the anterior part. There's one retractor, the inferior under the tal, and there's one more behind posterior. You can use a Mueller's retractor. You can see the tal very easily. The best part of a DA is the cup exposure is excellent. You can have a very good exposure of the cup. While reaming, make sure you're parallel to the floor. You're not too much antiverted, and you're close. So you can put a trial cup inside, and you can then take a shoot on the C-arm. The C-arm comes in. You can see whether you're going right up to the teardrop and how's the inclination inversion. And once you're happy with the trial, you can directly go for after the final cup. You can impact it and get a good fixation. Usually, you don't need to put screws if the bone is good, but in case if you feel that the fit is not so good, you can put in screws. And it's very easy to do everything like we do for a normal posterior or an anterolateral hip replacement. Everything, all the other steps remain the same. The main thing is the exposure. Once you get a good exposure, you're very happy to go about. So then we put the liner in, and then I'll directly go to the exposure of the femur, which is the most important part of DA, because most of the surgeons are scared in doing a DA because of the femoral exposure is not very easy. So to make it simple, what we do is we use a bone hook, and we identify the posterior part of the femur, and then I'm releasing the superior capsule. Once I release the superior capsule, I will try and elevate the femur with the help of the Mueller's retractor, and I will ask my assistant to push it. While my other assistant is adducting the leg, he is doing adduction, external rotation, and extension of the leg. You can break the table by 10 to 20 degrees to get the femur out in your first few cases, but later on, as you keep doing more, you don't have to even break the table. And then you start broaching. Once we have a good broach and a satisfactory fit, you can use a final implant to get the fit in. And then again, after putting this broach trial, you can take an X-ray C-arm shoot and confirm whether your approach is correct, whether your lateral is complete. So this is the position of the leg, which goes under the other leg and while we're doing it. And then we put a trial head. So this is the Mueller's, which is behind the GT. You have to make sure this retractor is not at the tip, it's beyond the tip, beyond the flare of the GT, so that you don't fracture the tip of GT, which is a very important tip. Once you have put in the trial, we take reduction, we can prepare the calcar. So all of the steps remain the same. The basics of total hip replacement remain the same. What is changing? Only the approach. I prefer using a collet stem nowadays because of the early mobility and stability it provides, as it also gives you the torsional stability. So once we put in the head, you reduce it, and you can then, the reduction menu is very simple. You use your thumb and index finger to reduce it, and then you can see on the C-arm how your implant looks like. And you can see a stability, mobility, and you can then close it routinely. So the closure is very easy. You just have to close the capsule and then just the fascia over the TFL and subcute. So the closure takes less than 7 to 8 minutes. It's very easy, very fast, and it's a very simple approach. And I think we all should start doing it because it's a very, very rewarding approach for the surgeon and also for the patient. Because patients with this approach have minimal pain. They are having very, very faster recovery. The recovery is very fast with minimal pain. They're able to do routine activities and able to walk very easily. So this is how the post-op X-ray looks like for this patient. So this is how it is, and I'm happy to take any more questions which you have. Thank you. Thank you so much.
Thanks, Rohit. Before we some questions comes on, I just want to ask you a few things. You said 1,300 hips. What percentage of your total hip replacements now comes on DAA?
Now it is almost 100%. I use maybe posterior only for revisions, very difficult revisions. So almost 99, 90, 98, 99% is DA now.
And if the patient needs bilateral, you will certainly do the bilateral with the same approach all the time?
Yes. All the time bilateral the same approach. We have revised a few surgeries also with DA. We've converted implant failures like a failed IT fracture with a PFN into a DA with the DA for a total. We've done a lot of bipolar hemiarthroplasties because I think neck femur fractures have already the patient have a very lax tissue and they have a high chance of dislocation if you do it through a posterior approach. So for any neck femur fracture, I would not recommend a posterior. You can either do a DA or you can do an anterolateral approach because the posterior will carry a higher risk of dislocation. So most of my patients now I'm doing is with DA, and we are using robotics now with the Mako. It's much more easier. You don't even need to do intraoperative X-rays. So the fluoroscopy is out. And the time taken initially for first few cases, it was, I think, first case took me around 2.5 hours for one hip. Now we are doing it under 35 to 40 minutes. It's that fast.
Do you think that fracture neck femur is case is a good to start with?
No, so it's such a fracture neck femur. I would recommend to start only after you have done 300 to 400 normal hip with DA, because fracture hip there are two problems. One is the patient has a porotic bone, so there's a high chance of fracture of the greater trochanter if your assistant is too enthusiastic, if it's pushing it too hard, you can fracture the femur because the patient already osteoporotic. The second point is, the bipolar head is bigger as compared to a total hip replacement head. So total hip replacement head is maximum 32, 28, 32, 36. But a bipolar head would be 44, 46. So reducing that bigger head under the rectus becomes a struggle. And if the rectus is too tight, then you struggle while reducing, and then you can cause a fracture.
Yeah, it's a good message. That's the reason I ask you this question, because people will think that, okay, let's start with the fracture neck femur, but that's not the right approach.
That's not the way to go, yeah.
Before we go to the question, I have just last question. Do you think that you already shown some good instruments which are curved, useful for DAA, but would you recommend that there are special type of stamps also for DAA which are more preferable, or any routine THR stamps which we are used or well versed with is okay?
I think any stem is okay while you're performing DA. So, but there are certain new designs which are short banana stems with collar. So these are more fancy. The companies are claiming that they're made for DA, but you can use any stem. You can put a corel, you can put a long stem. We're doing long stem bipolars also. What is more important is you need offset broach handles. You cannot do it with a straight broach handle, becomes very difficult because the broaches will hit the anterior part of the ASI. You need the curved double curved offset broach handles. And also for the acetabulum, either you can use a straight or an offset impactor. So these are two important things which are very important. So you should have them. And otherwise, you can do with any other normal instruments. You can have your normal spikes. You can use your molars, or which we routinely use for bipolars. So all other instruments are routine.
Easy to do cementing also?
Yes, we are doing cementing also. So porotic patients, it's very simple because the femur is right up. The acetabulum is very, very easily. So acetabulum is the most beautiful part for DA. The acetabulum is superb. You see 360 degrees of acetabulum very easily. And you can put your cup, inclination, everything is perfect. And you can take X-rays. The best part is if you're putting your cup, you can take live X-rays and see whether you're correct or not. Because cementing is, when you do it with any other approach, we are still not sure what's my inclination or anteversion is. But with DA, you can be sure where you can take intraoperative X-rays and you can get a very good cup fit with the DA, especially cemented.
There are a couple of questions if you can see.
Yeah. so difficult to identify the fascia capsule. It's not that difficult. So I want to know what fascia. There are two fascias which we encounter in this. First is the fascia which is between, which is above the TFL. So as soon as you cut the subacute, separate the fat pad, you see a fascia. That's a TFL fascia. It's very easy to identify. So TFL fascia, as I told you, will be purple in color or dark blue in color, while the sartorius will be more whiter, and it has perforators. Once you open this, you retract the TFL behind, and then as you retract the TFL, you will see the fascia, which is the underneath fascia. So TFL is a muscle which is in an envelope, so, right? So first we are cutting the top part of the envelope, and then we are cutting the down part of the envelope to see the capsule. There are two fascias which you encounter, and it's very easy to identify, and you can take it easy. And once you are on the top of the head of the neck of the femur, then you can identify. You can use your finger to palpate the GT. You can then run it over the intertrochanteric line. You can feel it easily, and then you can incise it. Now coming to how to cut, how to identify an incision. I think incision I've already told about. The incision would be 8 to 10 centimeters, 3 finger width below and behind the ASIs, and you can identify the fascia easily. It's you will see three vessels coming across the fascia, which we have to ligate or cauterize, and that's how it goes. Do we need femoral elevator, special table break, etc. for DA? So yeah, femoral elevator is important. So any normal femoral elevator which we use is okay. You can use Mueller's, anyone. And you need to have a table which breaks for your first few cases because you don't want to struggle initially. But now for last maybe 300, 400 surgeries, I've not done a table break because now I've mastered the art of release and it's very easy. And what are structures which are released on femoral side when the neck is short? So there's a slide, if you want, I can share, but I think because of restriction, the femoral release goes from, so first structure to release is the pubofemoral ligament. Then second we release is the superior part of the capsule. The superior capsule we release at the femur. We also release at the acetabulum because I think most important, the biggest culprit in a short neck femur is the tight superior capsule. Once you release the capsule, everything becomes easy. So pubofemoral ligament, superior capsule, then comes partial release of the conjoint tendon. And with this, most of the times you can easily elevate the femur. If you think you're still struggling with elevation, then you can move to piriformis. So piriformis release is required in less than, I would say, 1 to 2% of patients. And 99% of patients only with the pubofemoral ligament, the superior capsule, and the conjoint tendon release, you can easily elevate. 1% or 1 to 2% patients might need a piriformis release. And if at all it's too tight or if it's dysplastic and you're still struggling, then you can partially release the obturator externus. Now, obturator externus muscle is between 12 o'clock to 3 o'clock position when you're doing a right hip. So you should avoid releasing that because that is a structure which is the short external rotators for the posterior approach. And if you release posterior structures while doing an anterior approach, you're making the hip more stable posteriorly also, which is not a good thing. So you should avoid releasing the obturator externus and the short rotators as much as possible. But in very, very tight cases, if you're still struggling, you can do a partial release of it and you can easily elevate the femur. It becomes very easy. And once you start doing maybe 30, 40, 50 surgeries, you'll say it's easier approach than any other approach, I would say. Even it's better than the posterior or anterolateral. I do all approaches for the hip. I do posterior, I do direct lateral, I do anterolateral, I do right anterior. So, but DA is my favorite approach because it's saving time for me. And the best part is the patients are excellent there. If you perform a few surgeries and you compare your own posterior patients with the DA patients, you will see the DA patients are much more happier and they're much more mobile, faster as compared to other patients. They're able to sit down on the floor at 15 days. They're able to do everything. So
right, there are a couple of questions more, but I just want to ask you, you said about mobilization, you let them go early home and allowed to go to the commode. At what time you would advise them, number one, to start driving, and number two, very low sitting? So what is the protocol for these two daily activities?
I was also very skeptical when I started doing the surgery, and I did one patient who was mentally retarded, with the DA because I wanted to make sure that he was not listening to anyone. He was doing all funny movements before the surgery. Even with a fractured neck femur, he was moving it very badly. So for this patient, I did a total hip with DA, and because he was young, and so what happened is this patient, when I saw him in the rounds, he was already sitting cross-legged, and I was very surprised at how is he sitting, and he's doing everything. He was moving around normally, and he was very hyper. So that struck a light in my mind. So then I started mobilizing my patients earlier. I advise them to start driving at 15 days. They can sit down on the floor at maybe 8 to 10 days. Some patients, when we go for rounds, they're already sitting with their legs crossed. He said, okay, I'm pretty happy and I'm good. And the best part of the patients demand that I'm good to go. Can I go home? So that comes from the patient. So that's how it is. It's very, it's a game changer. So once we start doing it, we will definitely, we all will understand that this is the approach, which is the best approach for the hip. The problem is we all were not being taught with this approach. We all have mastered posterior because our masters were doing posterior and their masters were doing posterior. But correct. I think eventually this wave would come, and when most of the surgeons in India will also shift to diet anterior because this is giving very good results post-op, and the stability is superb. If you want, when you see the patient, when I'm doing a stability test on table, the DA is the only approach which allows me to check the hip globally. So I am doing posterior, I'm flexing the femur, flexing the knee, and giving a posterior thrust, seeing whether the hip is locating posteriorly. Then I'm extending the table 20 degrees, giving full external rotation, adduction, external rotation. It's not dislocated anteriorly. So posterior dislocation checked, anterior checked, and you can check full adduction, abduction. You can do figure of 4 on table because patient lying supine. In any other approach, when the patient is lying lateral, we cannot check all this movements. For posterior approach, we are only checking posterior dislocation. But there are certain patients who especially have stiff spine, and if you have given more anteversion, they will dislocate anteriorly with a posterior approach. And most of the surgeons are not checking anterior stability in a posterior approach. We're only checking posterior because we've been taught that. But in this, we're able to check everything. It gives you 360 degree. You can check it globally, and it gives very, very good results.
There are 2 more questions for you. 3 more now. And then we stop, I think.
Yeah, so is it easier for obese patients and those with abnormal pelvic morphology? Yes, it is not a good case to start initially. Yeah, but once you have done a few number of cases, then you can take these cases. In obese patients, I have done one patient who was 126 kgs recently. The fact is, we have a phobia of doing obese patients initially because we all feel that it's difficult to retract. But obese patients are easier because of the sense that they have more fat, the tissues are very flabby, that muscles are not very tight. In fact, more muscular thin patients who have very tight muscles are difficult initially. And also in obese patients, the advantage is you can do it easily with minimal retraction, and the patients are able to go home. And most of the time, the obese patients will have more fat behind. So the gluteal fat is bigger than the anterior fat. Anterior, the fat pad may be around 3 to 4 inches, but behind you might have 8 to 10 inches of fat pad in very obese patients. So that's how it is different. So difference blood loss in anterior versus, so anterior approach will always have a lesser blood loss because the incision is around 8 to 10 centimeters. We're not encountering any vessels. There are not much bleeders, only the 3 vessels which perforate the lateral circumflex artery. That's the only bleeder. Once you coagulate that, then there's no bleeding throughout. So it has definitely lesser blood loss, and the requirement for blood transfusions post-operatively is very, very less.
Dr. Khincha, any comment?
Rohit.
Yes, sir. Yes, sir.
This has been made to look so easy, of a difficult procedure, but I think it's been made to look easy because you've mastered the art of release, your anatomy, and your experience about the different layers. So I hope that anybody who wants to learn a new approach, or maybe a DA or any other approach, should make it a point to see the masters at work and pick up the point and come over, so that they are not making mistakes on the patient, because 1 in 1,000 or 1 in 10,000 problem is not too many. So my suggestion to the participants, maybe senior, maybe semi-senior or junior, is to go and visit people. That's how we learned our techniques of AO fixations or hip replacement or knee replacement. And so that is a point which should be taken. And I I'm very happy with the simplicity you have put the whole system of DA onto the table, and I'm sure it will stimulate a lot of youngsters to start doing it.
Let me take
I'll add is,
liberty.
one point I'll add, I'm so sorry. One point I'll add is, see, even when I started, I told you I had hiccups initially. So we all have gone through certain complications like fractures and everything. But, I would suggest all, especially the newcomers who want to learn this approach, or even senior guys who want to learn this. So you should start doing this by either initially reading about it, then maybe doing a couple of cadaveric courses, then visiting surgeons who are doing this, or call those surgeons to your hospital if you want to learn and show your team also. So don't start it right away, because it's not a cakewalk. It has a high learning curve. Once your basics are clear, then you can easily perform any difficult hip with this approach.
See, it was said in AO technique, in AO fixations, that the most dangerous surgeon is the person who does an elbow fixation on plastic bones and masters the art of the elbow fixation on the plastic bones, and next day unfortunately gets a difficult elbow and starts trying to fix the same bone like he fixed the plastic bone, and he is in a big mess. So that should not happen. You should have it alive, and you should go to a master, learn the techniques about not only where to cut, but how to hold an instrument, how to hold a forceps, how to hold a scissors system. And well done. Well done.
Thank you so much for this opportunity.
Rohit. And any participants, those who are very keen to learn on behalf of Dr. Rohit and other colleagues, we can certainly arrange and help you, as he said, for the cadaveric course and then one-to-one learning. But as Dr. Prem Khincha said, go to the experienced surgeon, learn from them. Ishq is very happy to support and guide and help any young surgeons who want to learn from the masters like Rohit. So thank you, Rohit. On behalf of Ishq, I appreciate your time and an excellent presentation.
Thank you so much.
May I request Dr. Dhanasekara Raja to start sharing his screen, Dhana?
Good evening, everybody. I apologize for joining late.
By the time Dr. Dhanasekara shares his screen, let me just tell you the next month is 9th of August. 16th of August, they have a Ganga course where Dr. Dhanasekara Raja is one of the organizing person. So 9th of August, we have two very eminent speakers like this time. We have Dr. Rajesh Malhotra from Delhi. He will be talking on hip, and Dr. Hemant Wakankar from Pune from the knee. And both are going to talk on intraoperative complications and prevention tips. So both very eminent surgeons. As Dr. Prem Khincha was saying, all these guys like Dhanasekar and Rohit and other people, those who are going to come subsequently, they're very hard, okay? They're very senior people and they're spending good time for us. So please take advantage, spread the message to your friends and colleagues. We can send you the Zoom link. It's available on OrthoTV also. So it's very easy now for everyone to join and learn from the masters. So Dhanasekar, on behalf of the Ishks team, the executive board, the trustees, and Dr. Prem Khincha, our president, I thank you for sparing your time and giving a talk on this role of stems and augments, sleeves in TKR. Thank you, Dhana.
Thank you, sir. My respect and regards to all the Ishq board members, and my greetings to our president, Dr. Khincha, and thank you, Dr. Dipak, the education chair. I'm going to talk about role of stem, augments, and sleeves in TKR. So stems, we know, provides a better added fixation, especially in case of a complex primary, and mainly it is used in revision scenario. It provides both metaphyseal and diaphyseal fixation where there is deficiency of bone in the metaphysis or epiphyseal bone, enhances mechanical stability, and it helps in load transfer to larger contact area. So main indications are bone loss, poor bone quality, revisions, and unstable or loose knees. Either it can be cemented or uncemented. So in primary, these are the indications where the bone defect, osteoporosis or osteopenia in inflammatory arthritis, where we need increased level of constraint because there is increased stress on the fixation. So we want to extend the fixation. Stress fractures, post-traumatic arthritis with poor bone stock, and obesity. In case of obesity, more than a BMI more than 35 or 40, with the poor bone stock, we always use a stem extension. So bone defect can be either a contained or uncontained defect. Most common classification system followed is AORI classification, and this is type 1, type 2, and type 3. Type 1 is localized cortical rim defect near the joint and requires either cement augmentation or bone grafting. Type 2 is cortical rim is intact, but there is a central or peripheral metaphyseal bone loss. Again, requires cementing or augments or sleeve fixation. It can be either 2A or 2B if there is one side, one condyle involved or both condyles involved. Type 3 is loss of entire metaphysis and ligament attachments will be compromised. So this require a higher level of constraint and more metal augments or sleeves or cones. In a varus knee, usually the defect is peripheral and is uncontained compared to a valgus knee where it is more of contained defect. So here the reconstruction is simple. We can add bone graft or bone cement, and this doesn't require a stem extension. As in this case, the central bone defect, it has been bone grafted and fixed with a screw, and doesn't require a stem extension. But in an uncontained defect like this, where there is a loss of cortical rim, we need to reconstruct with the bone graft or cement. So what are the options? It depends on the size of the defect and the percentage of involvement of the condyle. The size of the defect is less than 5 mm depth and involves less than 50% of the medial condyle. It is type 1. Type 2 is 5 to 10 millimeters. Type 3 is more than 10 millimeters. Type 2 and type 3 or more than that will require a stem extension because the fixation will be compromised and it will lead to early failure. We always try to reduce the bone defect, but we should never cut up to the base of the bone defect. We undercut. It has to be above the level of the fibular head, because below the level of the fibular head, the tibial bone strength decreases. So we undercut the defect and lateralize the tray so that the bone defect is reduced. In this scenario, we don't require a stem extension. But if the defect is more than 10 millimeters or involving more than 50% of the condyle, we need to reconstruct. These are the options. Less than 5 millimeters cement. 5 to 10 millimeters requires a cement with screw or a bone grafting in a younger patient. More than 10 millimeters requires an augment. So this is an example where an elderly low demand patient where cement and screws has been used for reconstruction. Here again, stem extension has been used both in the femoral and tibial side because of the bone loss and osteoporotic bone. So any defect less than 20 millimeters can be reconstructed with the cement and screw in elderly low demand patients. In a younger patient, you want to preserve the biology. We use this technique described as Kalko. We use the tibial plateau and then use some screws to reconstruct the bone defect. So we need to add additional stem extension in these cases. So we can see here the massive medial uncontained defect has been reconstructed with bone graft. And here again, we need to use a stem extension to protect the bone graft so that it doesn't collapse in the postoperative period. So whereas with FFD, posteromedial bone loss, both sides reconstructed with bone graft and tibial stem extension. Here we used a short cemented stem because of the osteoporotic bone. But you don't require a very long fixation unless there is a massive bone defect. This is an example of an elderly patient, severe osteoporosis, but very symptomatic, wanted to have the surgery immediately. So we have added tibial short cemented stem on both tibial side so that it gives added fixation and stability. When we increase the level of constraint, again, we have to add a stem extension because once we increase the level of constraint, the stress is taken by the implants. So to improve the stability, we add a stem extension in these cases. So in the severe valgus with medial laxity, we use a constraint type of processes. varus valgus constraint, where we need to add stem extension so that the fixation does not fail early. Another example, severe flexion deformity, where we use the constraint processes to avoid mid-flexion instability. Again, we need to add stem extension both sides. Anytime we increase the level of constraint, it's better to add a stem extension. Again, if you're using a rotating hinge type of processes where the ligaments are totally deficient, the entire fixation is taken by the stress on the implant is taken by the stems. So it is mandatory to use stems in hinges also. In severe osteopenia, where we are trying to correct a flexion deformity, as in the case of rheumatoid arthritis, it is advisable to add a femoral stem extension. So in this case, I had a F50 correction on table. It was stretched and patient developed a posterior cortex fracture. So to avoid this happening intra-op or in the post-operative period, better to have a femoral stem extension. This is one of the indications where in primary we use a stem extension in the femur. The only system where you can use a stem in the femur is the PFC system. In other implants, we need to get a revision femoral component. So this went on to heal. Both sides FFD is corrected, but on the right side we can see because of the intraoperative stress fracture, this formed a callus and healed well. To avoid that, better to add a femoral stem extension. This is example of a stress fracture on the varus knee. So if you have a stress fracture, it is advisable to do a single stage procedure. You correct the arthritis and correct the alignment and get your stress fracture also fixed. If you try to treat the fracture first, it is not going to heal and it will develop non-union because the alignment is not corrected and the knee will continue to be in varus. So any patients with stress fracture, it is ideal to do a single stage correction with a leg stem extension. So we can open the fracture site, temporarily fix with a small plate and then get a tibial stem extension so that the fracture is aligned and the limb also aligned, it goes on to heal. Another example where there is a thinner stem has been used. So you need to have an adequate distal fixation. Whenever you are using a stem for stress fracture, you need to have a longer stem, at least 3 to 4 cortical diameter from the fracture site, and better diaphyseal hold so that the stability is achieved on table. So you need to have a slightly longer stem and have a unsymmetric fixation with a stem of adequate diameter so that your distal fixation is achieved well. So the example where the revision of the longer stem has been done and a good union has been achieved with a longer unsymmetric stem. Another example where there is acute stress fracture. We are in a young, obese lady. You can see the stress fracture in the lateral view. I used a diaphyseal fixing unsymmetric stem, but here because of the tibial bowing, you can see there is a tibial bowing. The length of the stem could not be longer. So it is hitting the anterior cortex, and because of this, the span of the stem is not great. So it eventually went on to heal, but it took longer time to heal. So here the offset type of stem will be useful. When there is bowing of the tibia, offset stems are useful. We need to, that options also are available, and one has to be aware and need to do a pre-op planning and keep it ready on table so that we can bypass the coronal plane or sagittal plane deformity and get a good distal fixation. Revisions always stem is mandatory because the bone is compromised in the metaphysis and the epiphysis and diaphysis. So here we can see the tibial simple revision has been achieved with the intramedullary stem, cemented stem. Short stubby stems are used in to prevent distal very long fixation, because in case of any future infection, it's easy to revise these type of stems. Short metaphyseal fixing stubby stems are more preferred these days because the length of fixation is shorter, and in future revisions it's easier to remove this and then go for a diaphyseal fixation. How much length of stem has to be used and what diameter has to be used, whether cemented or unscemented, it all depends on individual cases. We need to do a pre-op planning, look at the patient's x-rays, age of the patient, bone quality, and what is the reason you are revising. These are all the factors which will influence. So the factors which influence length and diameter, severe bone loss, you need to have a longer fixation. So longer and wider stem to achieve a distal fixation. If you're using a cemented system, better to go for a shorter cemented system. either a 30 or 40, the shortest available stem, maximum up to 75, or generally stop at 60 or 75, and it is useful for metaphyseal defects. Press fit unsymmetric stems are useful for major defects. Need to have a longer stem, at least 4 centimeter of diaphysis has to be engaged. So we use a longer stem in this scenario, useful for very major defects, or you combine with augments or wedges or sleeve, we use a press fit stem. Again, we need to look at the anatomy of the canal. If there is a abnormal anatomy, we should arrange a offset type of stem, or you can go for a shorted symmetric fixation. Again, patient specific needs, why you are using it, because for poor bone quality, or you are using a constraint. These are the situations where we use a shorter symmetric fixation. Generally, you want a canal fill ratio of 0.7. So, meaning the stem diameter should be at least 70% of the medullary canal. So, that is will give you a good fixation. So, for a femur, at least 0.7 and more than 2 centimeter diaphyseal fixation. For the tibia, canal fill ratio of 0.85 is recommended. Problem with the stem, end of stem pain. Sometimes the stem is touching the cortex, it can cause pain. So, and to avoid this, now we are using a cemented metaphyseal fixing stem. Coming to metal augments and wedges, indicated in uncontained peripheral defects, where there is more than 10% of the 25% of the condyle is involved, or the depth of the defect is more than 5 or 10 millimeters, and has a very high success rate, especially in elderly patients. It's very useful. So generally, wedges have more biomechanical stability compared to simple cement with screws or bone wraps. So they allow immediate weight bearing, and the long-term fixation is also really good. The example of a severe varus deformity with a large bone defect, you can see the level of the defect is below the head of the fibula. So there is a good indicator for pre-op planning. You look at the draw a horizontal line along the tibial plateau at the level of the fibular head. If it is below that, definitely you need a stem extension, or additionally you need a augment also, or we need to go for a bone grafting. So here the level of the defect is below the fibular head, where I have to use a medial augment, medial wedge along with the fixation. Again, one more example, tibial collapse medial with a stress fracture, where I had to use a medial augment and the long diaphyseal fixing stem. On the femoral side also, cemented fixation has been used. On the tibial side, because of the fracture, I had to bypass the fracture and use an uncemented fixation. Is the example of using a metal wedge with a stem extension. Modular femoral augments, they are useful for both in primary and revision scenario. So this is an example of a type 2 valgus in a rheumatoid patient with lateral femoral condyle hypoplasia. Here I use a distal femur augment to reconstruct the lateral femoral condyle and bring down the joint line. And additional stem extension has been used because the bone stock is very poor and bone is very osteoporotic. So here we used a distal femur augment to reconstruct the femoral hypoplasia. Another example where there is severe hyperextension in this patient. You can see there is recurvatum, introp, there is huge recurvatum. Here to distalize the femoral component, we use an augment. You can see here, we have used a rotating hinge augment, but to distalize the femoral component, I used a femoral augment 10 mm on the both medial and lateral condyle. This is a post-operative X-ray. You can see the joint line is well maintained, and this is a patient walking post-operatively. Again, modular metal augments are useful in revision, both to reconstruct distal femur bone defect and posterior condylar bone defect. Example of a revision case where distal femur augment has been used. So generally, the role is to fill and manage bone defect both in the femoral and tibial condyle. It helps you to establish the joint line, especially in the femoral side. If there is bone loss, we can bring down the femoral component so that the joint line is restored. And usually, it's available off the shelf. Type 1 and type 2 defect can be reconstructed with augments. Another example in revision, where a complete augment metal wedge has been used, both in the femoral and tibial side. So the earlier cases we showed only medial tibial defect. Here the entire tibial plateau is deficient. So we used a total wedge to elevate the tibial platform. Next is sleeves. It provides metaphyseal fixation by either press fit or cemented fixation. Fixation is achieved with the help of a titanium poro coating surface, and it transfers the load to the metaphysis. It indicated for type 2 and type 3 bone defects. So very usually seen in revision scenario. Advantages of the sleeve is it's a ingrowth type of surface, so it is more biological. It helps to provide axial and rotational stability on the table so that immediate weight bearing can be achieved. Larger metaphyseal defect can be addressed, which cannot be addressed only with the tibial wedges. So we can avoid using a long stem. Previously, we were using tibial wedges with a long diaphyseal fixing stem. Now we are totally come off long diaphyseal fixing stems, and we are able to achieve metaphyseal fixation even in bone loss. And it's a very simple technique. We re-broach and fix the components. So this is how we do the preparation of the bone. You can see the medial condylar bone defect. So we open the medullary canal, use a small stem so that your reaming is along the medullary canal, and open up the medullary metaphysis, ream the metaphysis. Then we use a rasp. We prepare the metaphysis for the sleeve to sit. So it is like a Z taper. It's conical in shape. Once you get a good press fit, we can lift the limb and rotate the limb completely with the broach handle. If you are able to achieve that amount of stability, then you reach the final broach size. We have different sizes, and we can see how much we need to elevate the tibial surface to reconstruct the bone loss. And once you do that, we can, this is how it looks from the top. A good cancellous bone is prepared, and we can add a stem. The length of the stem again depends on the defect, the quality of the metaphyseal bone and the severity of the bone defect. And we can adjust the rotation, and then we get a fixation. Fixation can be either cemented, hybrid, or uncemented. We can use the sleeve with the stem or without a stem. So here this is typically how we use it. We put cement only on the surface of the tibial component, and the fixation is called hybrid. Permanent fixation is achieved by the poro coating, which is uncemented fixation. So this is an example of hybrid fixation. Then another example, in a patient with small anatomy, we use complete cemented fixation because most of the Indian patients have very small bone. Here we can use small sleeves which are available for a cemented fixation. On the femoral side, we used again a hybrid fixation, uncemented sleeve with a long stem and surface cementing on the femoral condyle. Another example where there is massive bone loss, you can see the bone loss below the fibular head. So this is more than 15-20 millimeters. So we are preparing the components, and here we are able to achieve good uncemented fixation. So this is purely uncemented fixation. You can see the X-rays. If you are able to get a good press fit with uncemented fixation, we can go ahead with a pure uncemented fixation. But we need to be careful. Make sure your poro coating has a good contact with the host bone. So this patient had a medial tibial condyle collapse. I prepared a sleeve, but unfortunately the sleeve size was smaller and I didn't get a good fixation, poro coat fixation. It eventually failed. I had to revise it. So make sure your poro coat has good host bone contact in the cancellous bone. So again, this is the last type defect, type 3 defect, where there is a loss of the entire medial and lateral condyle, with which the collateral ligament attachment also is compromised. Usually happens in infection when you have to debride a lot of bone, the ligament is compromised. Here the only option is to use the hinge. Always the hinge need to combine with a good fixation, either with a good diaphyseal uncemented fixation, or if you want to get a fixation, the metaphysis, it usually combined with the sleeve. So you can see the intraoperative picture, the loss of condyle, and the fixation has been achieved with the sleeve and the metaphysis. And this is how the intraoperative bone defect and ligament imbalance is looking like. And only option is to use a hinge. So here we use a sleeve on the femoral side. The tibial side, there is not much of bone loss. We use the short cemented stem. In the femoral side, we used a long diaphyseal fixing stem because of the severe bone loss. So your length of the stem is decided by the amount of bone loss. So here, when there is excessive bone loss and type 3 defect, we generally prefer to use a long diaphyseal fixing uncemented stem. Again, the biomechanical studies have shown that minimum 75 centimeter tibial stem is required for when you have a good metaphyseal bone. When the metaphyseal bone is compromised, we get a longer stem with a slight distal scratch fit, so that you will give adequate time for the sleeve to get fixation. Once the fixation is achieved in the sleeve, the femoral distal tibial stem fixation is not critical. This example where there is a malunited tibial component fracture with malunion, and you can see the osteotomy was done and the long stem has been used. Fixation of the defect, reconstruction of the defect has been done with the tibial sleeve, but because of the malunion and osteotomy, we have to use a diaphyseal fixing long stem. On the femoral side, the angular deformity of the femur does not allow a long stem fixation in a small patient. So I used a stemless fixation in the femoral side. Another example, infected TKR, two-stage revision. Here again, the femoral side, because of the good bone stock, I use a sleeve without a stem extension. Tibial side reconstructed with a just cemented stem. So these are the different ways we can get a fixation. Compared to cones, sleeves are more modular. They are off the shelf, but can be used only with one company, because the Depew PFC system is only has the sleeve system. The cones are more versatile. It can be combined with any implant, and it can be used for larger defects where entire condyle is missing, where you cannot get a porocoat fixation. We can use the cones. So coming to the conclusion, stems mainly used to bypass bone defect and provides the alignment also. The moment you put a stem, it gives you the alignment along the medullary canal. And fixation either can be in the metaphysis or diaphysis, used commonly in primary and revision with bone loss. Augments fill bone defect either in the metaphysis or the epiphysis. Only localized bone defect can be reconstructed with augments, both in primary and revision. Sleeve provide metaphyseal fixation, and the fixation site is only mainly metaphysis, and they are useful in moderate to severe bone loss. With this, I thank everybody for the opportunity. I'm happy to take any questions. Thank you.
Thank you, Dhanasekara. Before you take on some questions, a couple of points. You showed one X-ray where the tibial base plate along with the sleeve was away from the tibial bone.
Yes,
so is it okay that you can keep the tibial base plate and a distance between the base of the tibia and the plate, and you don't need to cement it? Is it okay practice?
So that's one of the cases, rare cases I did because I wanted to see how uncemented fixation will work. So that is purely uncemented fixation. And because there's a huge gap, I didn't use cement. Generally, we can fill up the defect with the bone cement, antibiotic bone cement, which will act like reduce the dead space and elute antibiotic. That's what I
But
did.
it is okay if the base plate remains a
Yes.
little up. It's okay. There is nothing to worry about.
Nothing to worry. That case, there was no problem. There was a good osseointegration, and there was no issue with that. So that is a modular looking system. The sleeve gets locked to the tibial component, and it's quite stable. So nothing happens in that.
As
My
long
second
as,
question is
as long as the rotational stability of the sleeve is good.
Yes.
And the sleeve does not have to go in the alignment of the anatomy of the tibia. It can go in any angle for a rotational stability on which the plate can sit. So I have fixed these plates above the tibia level on many an occasion without any trouble, and that fills up with whatever fibrous tissue. I don't put cement in there because I want natural tissue to grow in there. But you need to have a rotational stability of your sleeve plus or minus stem.
Good.
Make sure when
my second question, Dr. Dhanasekara, in a femur, because we usually see the bowing.
Yes.
So are these cases where usually we might have to go for a cemented stem, and probably the long uncemented stems may not be very useful? Is this your observation and suggestion?
Yes, sir. This is a problem with the femoral side sleeve. That's why the femoral side sleeve usage has come down, and more people are using cones on the femoral side because your angle with which the cone and the sleeve and stem engages is fixed. We cannot change it. So either we have to go for a short stem with a cemented fixation, or we have to go for a cone. That's a problem with the use of femoral sleeve. We have to see the lateral view of the femur. If there is excessive bowing, better to use a shorter fixation. If you use a long fixation, it's not going to extend the femoral component and bring the femur anterior. So that will lead to anterior overstuffing and patellar component problems.
And do not hesitate to see the IITV frequently on table, correct?
Yes, yes, definitely.
Yeah. I think there are a couple of questions there.
So first is
what are the different lengths?
Yeah, available. Each system has their own, each company has their own different length. What I commonly use is a debut system. The smallest is like 30 stem, the tibial side. Longest is 150. So these are the options. 30 and 60 are cemented. Beyond that, 75, 110, 105 and 150 are there. These are all uncemented. But each company has their own length and diameter combinations. You need to check with the implant company to choose your length. Next is indication of using femur stem. As I showed, very osteoporotic bone in a rheumatoid patient, I use an additional femoral stem extension. Anytime use a higher level of constraint, TC3 or LCCK type of implant, I use a femoral stem. All revisions, femoral stem is mandatory because already the epiphysis bone is compromised, distal femur bone is compromised, need to add a stem. In a valgus knee with the lateral condyle hypoplasia,
recording stopped.
I have used femoral stem extension. These are the indications. Yeah. Sleeves are more of biological fixation, cones are more of mechanic. Is it so? Both have biological fixation. The sleeve is fixed to the host bone and it gives ingrowth and gives stability. Cones also directly fixed to the host bone. They are not fixed with cement. All cones are uncemented and you need to prepare them properly and get a proper press fit on the table. The implant fixation to the cone is cemented. So there is some amount of cement there also, but the fixation of cone to the host bone is uncemented. So it gives good stability and fixation in the metaphysis. The fixation of the prosthesis to the cone is cemented. So both are biological, both are equally used, and both are biological fixation will give you fixation in the metaphysis so that you don't need to use a long diaphyseal stem. You can use a short cemented system just to get a fixation into the cone.
Dr. Dhanasekara, your suggestion on in one of the slides you showed about use of stems in obese patients.
Yes.
So what's a clinical guide you would give to the colleagues that what type of stem use at what limit in obesity?
So generally obesity, it's indicated, the stem usage is indicated because many papers have suggested there is high incidence of tibial component loosening in obese patient, especially there is some amount of varus. So varus more than 2 or 3 degrees is not well tolerated in obese patient. My clinical criteria is I look at the quality of the bone. So quality of the bone is most important thing. And the component placement, especially the tibial component, we should not tolerate any varus or valgus. So the quality of bone is good and I am happy with the component placement. I generally don't use stem, even with the obese patients of more than BMI 40, I've been not using it. But the bone quality is not good. There is some amount of osteoporosis and I'm not sure about my component placement. I always use a tibial stem extension, any patient beyond 35 BMI. 35 or 40. So simply using a stem alone will not give good long-term fixation in obese patient. You have to make sure your component placement is correct and balancing also correct. So one of the papers have shown that comparing BMI less than 30 and more than 30 with the use of stem, patients having stem had a higher incidence of loosening. I think this is from the Australian registry, I think. So stem alone will not give you good long-term fixation. Balancing is also important. So any patients with poor bone stock, more than 35 BMI, I use a stem extension. Usually it's a short stem, short stubby stem, cemented fixation, which will give additional fixation in the metaphysis.
The one which you said 30 mm.
Yes.
Correct. Okay. Dr. Khincha?
No, I can't add anything more to the extensive coverage of Dr. Dhanasekara Raja. And at this time, I want to acknowledge all the hard work put in the last few years, and acknowledge the hard work he's going to put in the coming years for the Ishks teaching programs. And my only request to all the participants is that please spread this word about this good, scientific, simple take-home messages from this Ishks online teaching, so that we have more than 30. Today we have 25, 28 participants, but I want to hit the mark of 100.
No.
So wherever possible,
no. Dr. Khincha, there are many those who are on OrthoTV live.
Oh, okay. So there are quite a lot of things. So I'm very happy, and we like more and more participation, and also the fact that youngsters who have shied away from this are encouraged to interact with the senior consultants, so that we can identify you and get you on the podium of Ishk in the near future.
Yeah, I think that concludes this today's scientific program on behalf of Dr. Khincha. And there is one more question, I think, Dhana, for you.
Okay.
Oh.
That's for you, sir. Can a foreign surgeon be member of Ishk? At present,
I have no answer to that. It doesn't. Do you know the answer to this, Dipak?
Yes, sir.
Yes, they can. Yeah.
They can be a member.
At present, we are not accepting this question.
We are not accepting?
Some applicants came from Nepal and Bangladesh because they need to be registered in India, Indian Medical Council, to be part of our society. So at present, we are not accepting.
But we encourage them to come. We encourage them to come as delegates and participants in any of the Ishk annual conferences, so that the word can be spread out. And then, if they are good enough, we will encourage them to come as a faculty in the near future.
So from Nepal, that's what he's asking, Dr. Rajiv. So unfortunately, at present, we are not accepting international members. Probably we'll work around it. Probably Dr. Khincha can guide again.
let me. I can't do this individually. I'll talk to the trustees and get the whole system organized. I'll talk to Vikram and Coimbatore and come back to you about this. And feel free to contact any of us.
Yeah. Okay. I think that's the end of today's program. I thank Dr. Dhanasekara Raja and Dr. Rohit Luthra and Dr. Prem.
Thank you so much.
Khincha to be here
talk,
for this program. And the reminder, the next one is on 9th of August, Saturday, same time, 7 to 8:30. Dr. Rajesh Malhotra and Dr. Hemant Wakankar. They are going to be speakers. Please spread the word. We have the link available on OrthoTV. Tell your friends and colleagues to be part of this. And thank you, Rohit, and thank you, Dr. Dhanasekara.
Yeah, I wish to personally thank Rohit and Dr. Dhanasekara Raja, and Dr. Dhana looks to be a very tired man. He looks to have he looks to be sleeping off with his eyes being off. Have a cup of coffee, have a good meal.
Maybe he has a couple of more surgeries to do, huh? He has a couple of more surgeries to do.
Thank you.
Excellent talk, Dr. Dhanasekara.
Yeah. Good night. Good night.
Thank you so much. Good night.
Bye.
Bye.